Is this working? Oh, perfect. Okay. So I'm going to talk about systematic reviews, myths and facts. And first of all, we have to define what is a systematic review. A systematic review is a literature review focused on a research question that could be as broad as exercise and the effectiveness in low back pain, or as small as effectiveness of shockwave in Achilles mid-portion tendinopathy. A systematic review is trying to identify, appraise, select, and synthesize all high-quality criteria relevant to this topic, to this question. And systematic reviews of high-quality RCTs are crucial to evidence-based practice. And this is what we know for the moment. The facts about knowledge and about data. More than 30,000 articles are published annually with about a 7% increase, 3,500 articles related to physiotherapy. So if I want to keep up to date, I have to read 10 papers per day. It's feasible to read 2 papers per day. So after 1 year, I will be 4 years behind from the evidence up to date. So there is an information overload in terms of medical research. And that's why systematic reviews have become increasingly popular. And this is not the only way because of the too many information that we have. It's also because systematic reviews are at the top level of evidence because it's filtered information. And this is the basis of evidence-based clinical practice in terms of clinicians' perspective and if they want to keep up to date. And from the other perspective, the guideline developers use the systematic reviews as a starting point to develop clinical guidelines. Today I will discuss about the systematic reviews not as an end point of the research, but as a starting point of the research in clinical terms. My presentation will focus on myths and facts, and because the concept is very broad, I would like to make it smaller, so we will focus on the shockwave research because it's also very popular nowadays. I will change my scientist's hat with my clinician's hat in this presentation, and I will give you an outline what we will try to deal in this talk. Do we need RCTs in clinical practice and generally research? Do RCTs adhere to guidelines? Are good quality RCTs published in high impact factor journals or better or good journals in general? Are percentages reported in the papers enough? So it means 82% of improvement is enough for the clinician to use it. Do systematic reviews aim to minimize bias? Because this is what systematic reviews do. Are quality assessment tools that try to assess the quality of the papers included in the systematic review good enough to be used? Are randomized controlled trial an efficient way to use them to create clinical guidelines? More than 10 years ago, the Cochrane group stated that randomized controlled trials are not the best way to use evidence in terms of clinical practice, but we still use them. Can we rely on statistics and use them for clinical interpretation? This is what are we going to deal with. So, systematic reviews do not adhere to guidelines. Even though several years ago the PRISMA guidelines have been updated in order to help readers and reviewers to assess the quality of systematic reviews, because as for the primary research, the same applies for the systematic reviews, they are not, we cannot assess their quality if we don't have the tools to do this. So even if guidelines are published, still systematic reviews are published without using these guidelines. So we cannot assess their quality. Another basic question: if I read a systematic review in a high impact factor journal, can I be more sure, more confident that the evidence is solid? Maybe, because the good journals use a robust peer review process, they use quality criteria, they use reviewers that are expert in the topic, and also they use several other criteria. But maybe this is not the case. As a standard practice here in Aspetar, we try to review our protocols annually or every 2 years. So a few months ago, somebody required for me to review the protocol for shockwave in general conditions of the lower limb. I did what every clinician would do. I searched literature to find a systematic review, and I found one published in American Journal of Sports Medicine, first out of 67 orthopedic journals with an impact factor about 5. So it means, for me, my job was done. And went to the conclusions, and this is what every clinician is doing now. Read the systematic review, go to the conclusions, and you see there is moderate level of evidence and should be used shockwave for the treatment of greater trochanteric pain syndrome, Achilles and patellar tendinopathy, if nothing else is working before surgery. So we can say that shockwave is effective, and we can use this in clinical practice. Actually, when we dig deeper into this systematic review, we found not only 6, but 21 mistakes. Oops, sorry. English is not my first language, so for me, mistakes and inconsistencies, as Rod told me to say, it's the same thing, but we found 21 inconsistencies. So you cannot rely on a high impact factor journal in terms of level of evidence when you search in systematic reviews. But we found the inconsistencies in self-rated improvement outcome measures. That means, for me, that I'm a clinician, what my patient would say about his improvement. So they ask the patients, how much do you believe that you are improved during this treatment modality? Let's focus on one paper. This paper assessed the effectiveness of eccentric load compared to the shockwave additive to eccentric load. And this is again from the American Journal. I have nothing with the American Journal of Sports Medicine, but all the good research is published there. And as you can see, several articles are published in American Journal of Sports Medicine. So they randomized the patients into 2 groups, eccentric load and shockwave additive to eccentric load. And the authors reported that 56% of eccentric loading patients were improved compared to 82% of the conjunction shockwave and eccentric load. What this means for me if I read the paper, that if I use shockwave along with eccentric load, I will have a better outcome, because 80% is for sure more than 50%. But what means 82% for me, or for the clinician, or for the researcher? Does it mean 8 out of 10? Of course not, because the percentage is affected by the sample size and also is affected by the type of the patient. As you know, we have the typical patient, but we have the patient that will not improve so good as the typical patient, so it's the worse than the typical patient, and we have patient that is better than the typical patient. In reality, if I will repeat this experiment, for example, I will do the same study, I will find 8 out of 10, and Rod will do the same and will find 8 out of 10, and Zalal the same, and somebody else the same. No, this would happen in a parallel Siban. In the parallel universe, excuse me. But this, in reality, we have somebody will do this and will have 8 out of 10, somebody else will have worse than the typical patient, so we have 6 or 4 out of 10 improvement, and some others will have better patients, so we have 9 out of 10. If we repeat this experiment, we'll have 7, 8, 4, 3, and that it's built a normal distribution that has 95% confidence intervals. What this means for the clinician, it means that the result of this experiment are within these limits, and I can be 95% sure that this will stay there. All the percentages have 95% confidence intervals. And in some cases, these are not reported in the primary research. But we can calculate it, and it's very easy. If we plug in the numbers, P with asterisk is the possible percentage, P is the observed percentage, and N is the sample size. Let's take the example of the RCT that we discussed a few minutes ago and see these percentages. 82% that is reported is something between 69 up to 95%. And 56% is something between 39 and 73%. And if we check this from a statistical perspective, there is an overlap. So it means there is no statistically significant difference between these 2 percentages. Even though 80% of my patients were improved compared to 56%, this is not significant. In clinical practice, when you discuss about percentages, have in mind that 1 out of 10 could be something between 0 to 29%. 4 out of 10 is not 40%, but something between 10 and 70%. And 3 out of 4 is not 75%, but it's something between 33 and 100%. So, the self-rated improvement is important. It's important to assess it because I'm a clinician. And if we check this systematic review that I was referred a few minutes ago, they reported 2 times improvement instead of 1.5 times. It's not a big deal, but they reported also 3.6 times instead of 6 times. And this is important. And when I read a systematic review, I want 2 things, accuracy and precision. And we don't have it here. So we sent a letter to the editor along with Rod, and we got a very, very, very non-informative response, and that's the end of it. So we said that systematic reviews are trying to minimize bias by using a strict way to do this in locating, selecting, coding, aggregating, and interpreting results, and this strictness is what makes these reviews systematic. But by definition, when you start searching the literature, you have to decrease the bias. And as you can see here in this table, there is a list of all the published systematic reviews from 2012 up to date regarding shockwave effectiveness in lower limb tendinopathies and conditions, including plantar fasciitis, Achilles tendinopathy, patellar tendinopathy, and the vast majority of them has publication and language bias. This is the search strategy of these systematic reviews. So in the beginning, they start with bias. And what means publication bias? They never search grey literature. They never search trial registries. And what is language bias? Everything is published in English. Nothing in Greek, nothing in Spanish. Again, systematic reviews do not aim to minimize bias. Let's check the primary studies that are included in systematic reviews. Here we have 2 double-blind, randomized placebo-controlled trials, top level of evidence. These 2 studies assess the effectiveness of shockwave compared to placebo shockwave in Achilles tendinopathy. When we check about these studies in a systematic review published in 2014, we found out that these 2 studies included patients that was a mixed group of mid-portion and insertional Achilles tendinopathy. If I do the search again, and I will miss this systematic review, I will find another systematic review published the same year in another good journal. Both of these journals are in top quality, high level of evidence. In this journal, this systematic review says that these 2 papers has to deal with mid-portion Achilles tendinopathy. So my clinical decision or the evidence I will use in my clinical practice depends on what these systematic reviews say. If I read one paper, it's a mixed group of Achilles tendinopathy. If I read the other paper, it's a mid-portion Achilles tendinopathy. So I take wrong conclusions. The thing that they agree, all 3 systematic reviews published about these 2 papers, including these 2 papers, is there is no significant difference between the groups in pain reduction and in generic health status patient-rated outcome measures. And there is only one study found significant differences in function in non-condition specific questionnaire. It's not Visa A. If you want to assess function in Achilles tendinopathy, you will use Visa A. And these are the results of the systematic reviews. No effect according to the forest plots, as you can see here, between shockwave and placebo shockwave. So I will never use shockwave in my Achilles tendinopathy patients. Is this correct? To assess the level of evidence, we have to assess the quality of these 2 papers. So in one systematic review, the one paper takes 90 out of 100, and the other one takes 70, and according to Pedro scale, and according to Dawson Black's checklist, this is quality assessment tools for systematic reviews, the one takes 24 and the other one takes 25 out of 28. So the level of evidence is high because these studies are of high quality. No evidence between shockwave and placebo shockwave with high quality evidence and with forest plots showing the same thing. Is this correct? I will give you another example to make it easier for you. A few years ago, I was invited to give a talk about the effectiveness of exercises and low back pain. And I did the same thing as I did when I'm trying to find evidence about shockwave. I searched the literature. By these years, you probably know these authors, and you probably know this group. Top quality systematic reviews about the effectiveness of exercises in low back pain. And the results showing what? There is no evidence that one particular type of exercise is better than other. And there is little or no evidence, and this is very, very important, in the difference between bed rest, you cannot hear me, you can hear me, between bed rest, exercises, and physiotherapy. So why what I found in my clinical practice that is effective, because I do exercises to treat low back pain, is not reported in systematic reviews. Why systematic reviews do not provide evidence for the effectiveness of exercises in the treatment of low back pain? So there is no reason for my existence. I will reply to this question with another question. How would you treat a chest pain? And this is the question that I searched in the literature about the exercises and low back pain. If you want to answer this question, you can do very easily a randomized control trial. Let's do a randomized control trial. Let's take a group of chest pain. This applies the same with mixed group of Achilles tendinopathy, insertional and mid portion, or this group applies with a non-specific low back pain. And then we randomize the group into the sample into three different groups. The one group will take nitroglycerin, the other group antacids, and the other group placebo or nothing, or will take eccentric load or placebo shockwave or eccentric load plus placebo, and then you will get these results. There is no difference between the types of exercises, or there is no difference between physiotherapy, bed rest, or exercises. If we change the non-specific chest pain, or the non-specific Achilles tendinopathy, or the non-specific low back pain into a specific pathology, that would be angina, then the results will be different. So this is a big problem in RCTs. You will never do a high quality in terms of clinical interpretation RCT if you will not have a homogeneous subgroup. And in order to have a homogeneous subgroup, you need valid and reliable tests, and also you need prospective cohort studies assessing this homogeneous group by using a specific treatment. And when the specific treatment is effective, then I can compare the different treatments. You can never use a systematic review in non-specific pain. Sorry about this, but we don't need systematic reviews. And in terms of Achilles tendinopathy, there is evidence, not only at the molecular and biological level, that insertional and mid-portion Achilles tendinopathy are two different entities, but also there is evidence that there is different treatment protocols for insertional and mid-portion Achilles tendinopathy. And let's go further, there is subgroups within the subgroups of Achilles tendinopathy. So I will never say that using an RCT with a mixed group of Achilles tendinopathy could give me the results that I can use in my clinical practice. How can the systematic reviews try to assess the quality of the studies included in the systematic review? They have quality tools. These are all the quality tools used in all published systematic reviews regarding shockwave the last decade. So we have Cochrane risk bias, we have Pedro scale, Coleman, Downs and Black checklist, and Zadar and whatever. To understand what's going on with these quality assessment tools, here is the distribution of all the published studies assessing shockwave in lower limb. And on this axis, you can see the score of these studies in Downs and Black checklist. And in this axis, you can see the impact factors, the impact factor of the journal that the study was published. And the distribution, the regression line shows that if you have a good quality in terms of checklist study, then you can publish it in a high quality journal. Let's check one of these two studies that has a high quality score, 25 out of 28, published in a journal of about 3 to 4 impact factor. This study is this: shockwave treatment for medial tibial stress syndrome in athletes, a prospective controlled study. Sorry, Adam. I never met Adam. They told me he was here. So, according to the Downs and Black checklist, this study has 25 out of 28. If I will change the quality assessment tool and I will use the risk of bias, I will find selection bias because it's non-randomized. I will find performance bias because treatments were not blinded, and also there is a difference in the amount of treatment the groups received. The one group received also shockwave. I will find attrition bias and detection bias because the outcome was not blinded. So the quality of the studies assessed by quality assessment tools, but the tools are not the same. They are not ranked in a way that we can know what to use in terms of what we want to assess. Problem again. This is the risk of bias, and assess selection bias, performance bias, detection bias, attrition bias, and reporting bias. There is something we are missing in the assessment of quality of the primary studies. And what is this? Let's check this study. Again, sorry for the American Journal of Sports Medicine. PRP compared to shockwave in patellar tendinopathy. Let's see the inclusion criteria. The criteria they used in this high-quality randomized controlled trial to assess the patients and make a homogeneous group of patellar tendinopathy. They used ultrasound examination by a clinician with 10 years of experience, and they also used clinical confirmation, no report about this. We know that not all painful tendons have increased vascularity and vice versa. We know that tendon pathology is not always painful, and we also know that there are no valid and reliable tests established for the assessment of patellar tendinopathy. So, are we sure that all these patients had patellar tendinopathy? Let's go further to another study. No difference in the effectiveness between focused and radial shockwave therapy in patellar tendinopathy. In another randomized controlled trial of high quality. What they used? Palpation in the inferior pole of patella. Okay, but they used something that is condition specific. They said that vis-a-vis should be less than 80. This is something, but a few years ago I did the cross-cultural adaptation of vis-a-vis in Greek-speaking patients, and we found that other knee injuries could score less than 80 in this questionnaire, because by definition the vis-a-vis questionnaire is not a diagnostic tool. It's a tool that you use to assess the pain and function in patients with tendon pain. And this is not from only one study. There is another study showing the same thing. Again, we are not sure if the patients included in this high-quality randomized controlled trial have all patellar tendinopathy. And let's check again another study, high-quality RCT, assessing home training, corticosteroid injections, and shockwave for greater trochanteric pain syndrome. Inclusion criteria: pain located anterior, lateral, or posterior to the greater trochanter. It seems good. This is the pain patterns when you make injections to the low back and SIJs. And this is another study replicated with double injections showing that the pain from the low back or the SIJs have a distribution anterior, lateral, or posterior to the greater trochanter. In this study, they used also some other inclusion criteria. Pain while lying on the affected side. I will not discuss about this, but they use a test, resisted external rotation in 90 degrees of hip flexion and knee flexion, and they also use non-radiological imaging. If you don't have radiological evidence, then you might have greater trochanteric pain syndrome. Because if you have radiological evidence, then you have osteoarthritis. Let's check each one of them. The test that we should use to decide if we have greater trochanteric pain syndrome or hip osteoarthritis in lateral hip pain is not external rotation resisted. It's Faber test. And if the pain is located anterior, posterior, or lateral to the greater trochanter, then the test we should use is Ober. And if it's negative, then you have to find the ratio between passive and active range of motion in order to decide if the patient have greater trochanteric pain syndrome. So again, sorry, this high quality RCT, I'm not sure that have included a homogeneous subgroup. And they used also imaging. 3 expertise in MRI assessed patients blindly, and they made this diagram that shows with orange is asymptomatic hips, with blue it's symptomatic hips. A big rate of these hips were rated as having no pathology, even they have pathology. A big rate of asymptomatic hips were rated as having bursitis, and a big range of them was rated as having tendon pathology and bursitis also. So we cannot rely even on imaging. We have to answer a couple of more questions. How systematic reviews measure improvement, so I can use it in my clinical practice. How the patient measures improvement, and how I will measure improvement. The systematic reviews provide a forest plot that for some clinicians means nothing, but generally if something is on the left that is for shockwave, it's effective. If something is on the right that is controlled, it's not good. So you can have an idea by looking this. Or maybe this has to do with pain. Or maybe they will use another forest plot by using functional scales. In most of the cases, the functional scales are not condition specific. Let's see how the studies assess pain. This is a study assessing shockwave compared to placebo in Achilles tendinopathy, and there is no statistically significant difference in all pain scores between the groups. And let's see something that is relevant for the patient. Pain during sports participation. No difference between shockwave and no difference in pain reduction and placebo shockwave. Not statistically significant. Even there is not even a trend. Same thing applies for the systematic review. So this study said no effect. The systematic review confirmed that there is no effect. We will discuss now about the visual analog scale or the numeric rating scale. We created this in order to understand in an objective way what means pain, much pain or less pain for a patient. And you can use it in a statistical way to say that there is significant difference between the baseline pain and the reduction. So if you had a pain 7 out of 10 and now the pain is 6 out of 10, and you have a big sample, you can say that there is statistically significant reduction. It's 1 out of 10 significant. Unfortunately not, because here you can see with different lines, different baseline pains, and as you can see, patients, in order to say that they are minimally improved, they answered that the pain reduction should be something between 20 and 30% of their baseline pain. So if you see a difference in a VAS scale and say from 10 out of 10, now I'm about to 7, for you is significant, but for the patient is minimal improvement. A patient, in order to say that something is significant for him, it's something between 40 and 50%. What we did with Rod, we took all the studies and we tried to distribute these studies based upon this criteria, what means for the patient clinical improvement. And this is the study we discussed before about shockwave and placebo. You can see that the placebo group was minimally improved compared to the shockwave group that was much improved. And this is not from the statistical perspective, this is from the clinical perspective. This is from the perspective that we want to hear in our clinical practice, what your patients believe about the improvement. So, no effect between shockwave and placebo. Sorry, in clinical terms, I have another story to tell. Something else that systematic reviews will never tell us. These are the forest plots about the effectiveness of shockwave and patellar tendinopathy. And as you can see here, the thing that the systematic review will never tell you is that there is no linear dose-response relationship. What this means? This means that in this study that assessed shockwave and placebo in patellar tendinopathy, they used high-energy shockwave, and the placebo shockwave, even though they use a gel, a pad gel, there is some energy going through. So in this study, they assessed, actually, because they said placebo and shockwave, but they assessed the two extremes of shockwave energy flux, the lowest and the highest. But as you can see here, if you have something between these two energies, then your results would be better. And you can never interpret this if you don't read the papers, because systematic reviews do not provide this. This study, the placebo-controlled study, said no effect in shockwave therapy in patellar tendinopathy. And this was a statement in the paper. If you read this title and you go again to the conclusions of the paper, never use shockwave in patellar tendinopathy. And something else, a form of bias that you will never see in systematic reviews. With red is all the published studies assessing shockwave in lower limb, and with green, all the published studies from one research group, and all the greens are from all the other research groups. So what is important? One research group did 50% of all the published studies assessing the effectiveness of shockwave in lower limb. And if we see a little bit further, 100% of all the studies published by this one research group found favorable results in terms of shockwave effectiveness, compared to only 20% of all the other research centers. This is a kind of bias that I cannot define. Maybe there is a conflict of interest, but there is nothing stated in all the individual papers. Let's discuss about the facts now. Do we need systematic reviews? Of course we need systematic reviews, but we need systematic reviews not as an end point. We need systematic reviews as a starting point, that we can have an idea and then we can dig deeper and see what's going on in the primary research studies. Do systematic reviews adhere to guidelines? Of course not. We have to do something about this, and we have to find and justify guidelines so we can assess the quality of the published systematic reviews. Are good quality papers published in high quality journals? Sorry, no. Are percentages enough? Percentages are never enough, because they have 95% confidence intervals, and we have to assess it in our clinical practice, because our patients are not usually the typical patient. Do systematic reviews aim to minimize bias? Sorry, no, because by definition, in the beginning, in the searching, there is language and publication bias. Are quality assessment tools efficient? Again, no, because there is no grading, there is no quality assessment of the quality assessment tools, so I can know what I can use in my systematic review. Of course, randomized controlled trials are not the basic research that has to be done in order to find clinical guidelines, and I show you the why. And we cannot rely on statistics for clinical interpretation. We have to rely only on our patients' perspectives. And something more. Most RCTs and systematic reviews assess the shockwave as a monotherapy. We never do shockwave as one treatment therapy. We use shockwave with eccentric load, we use shockwave with strategic loading, we use shockwave with something else. And this is never assessed in systematic reviews. And sometimes, not sometimes, 90% of the times, we individualize our patient's treatment according to evidence-based practice that has to do with the evidence, with what I know, and with what my patient wants. Because not all of us are they cannot do this digging. This is a must-read paper from Claire. I will not try to say your last name because my tongue will have a sprain. And there is 5 things you have to assess in systematic reviews and assess the quality of the systematic reviews. It's a very interesting editorial published last year that can help every clinician to assess the quality of the systematic reviews, a must-read paper. Take-home message: demand evidence and think critically. Thank you.